University of Uganda, and tonight I'm delighted to be talking about the physiology of tubules, nephrons. So let's get it started. As you can see down here, there's something that I don't know. There is something that I cannot give a meaning, that I cannot give explanation. So be sorry for that. I'll be trying to share the knowledge that I have so far. So the knowledge on some poets can't be described, KX. So let's get started. So this is a part of the nephron that it comes after Bowman capsule. There have been filtration at the level of glomerulus. Then after filtration, we have here afferent, which get into different capillaries, batch of capillaries, then goes out as efferent. So as you have afferent, there is some sodium which comes out. There is some glucose which comes out. There is some potassium which comes out, and there are some urea which comes out. And there is again creatinine which comes out. So this is the solute. This is the content that we get from filtration. This is in the Bowman capsule, and this solute is going to be going in these proximal convoluted tubules. So in the proximal convoluted tubules, what happened? So all of these, this is what you have right here on the side of rumen, urine. So we have sodium, have glucose, have potassium, and also we have urea and creatinine. We have to reabsorb some and have to excrete some. So sodium, as you can see, it gets reabsorbed together with glucose. Also, they say 100% of glucose get reabsorbed. 18% of potassium get reabsorbed at the point of proximal convoluted tubules. So the same as potassium. So creatinine and urea, mostly they are not reabsorbed at this point. But as you can see, acid start to get out from the body, have come from these cells for the point to reabsorb. Bicarbonate, we reabsorb it indirectly. So we secrete acid to recombine with bicarbonate to give carbon dioxide and water. And this carbon dioxide and water can pass into proximal convoluted tubule cells, and it is formed bicarbonate. The same as the one that we're having right here. So this is the process. This is how we absorb bicarbonate, glucose, sodium, and some part of potassium, of course, get it absorbed. So next, we have reabsorbed some sodium, but it remains some potassium, remains some. So this is the thick ascending rim. Why ascending rim? Because rope of Henle, we have descending and ascending. This is descending, this is ascending. For the poet of descending, it is permeable to water but impermeable to solutes, including sodium, potassium, impermeable to solutes like sodium. Then on the thick ascending parts, this ascending part, they get to be not reabsorbed to the water, but red sodium comes out from the urine. So at the point of rope of Henle, we keep reabsorbing sodium, we keep reabsorbing potassium, we keep reabsorbing chloride from urine. So far, the things that were found to be excreted in the urine, it's acid. The same as magnesium and potassium reabsorb through this space between cells. And at this point you can find that there is excretion of some amount of potassium. So this is a part of group of Henle. So anything that will disrupt the physiology, the way things work, the something which was supposed to be reabsorbed, it is not going to be reabsorbed. The something which was supposed to be secreted, it is not going to be secreted. So for particular disease condition, you will find that urine sodium gets higher because it has affected the process of reabsorption. Potassium gets low because it has affected the process of reabsorption. Acid gets low because acid was supposed to be excreted or secreted in the urine. Then it has not been secreted because there have been some disruption of the pathological conditions. So this is the distal convoluted tubers. Mostly in the distal convoluted tubers, but much it's calcium. Calcium gets reabsorbed at this point, but remember we found that this point also reabsorbed here. So in this case I was showing some diuretics which might block sodium chloride channel so that sodium cannot be reabsorbed and the water flow, and someone may excrete low concentrated urine. So these are the point where parathyroid hormone act. Parathyroid hormone act here because it was to reabsorb calcium. Kidney has to reabsorb calcium because the stimulation of parathyroid hormone. So at this point you can see nothing secreted in the urine. There is not added content. So for the things that we found to be added, there was acid and potassium to some point. So this is the rusty part of tubers. Correct. In the urine, chloride keeps moving out. Sodium, because of ADH, gets out vasopressin. It keep water comes in with antidiuretic hormone, because this antidiuretic hormone is going to lead to aquaporins vesicle movement on the membrane, and these aquaporins, as they get to the membrane, they become into channels that are going to be letting water comes into the cells and we reabsorb water. And then you can see aldosterone, a best friend for renin angiotensin aldosterone system, which lead to reabsorption of sodium at this point from urine, and then excretion of potassium get out in the urine. And you can see some medication which blocks sodium channel, amylolide and triamcinolone. These medication, they're going to block reabsorption of sodium. But the difference between this medication and the one which block aldosterone, it is because this medication has nothing to do with potassium, but one which affects aldosterone affects sodium and potassium at the same time. This is something that you need to differentiate. So here we have other type of cell known as intercalated cells. We have a principal cell and you have intercalated cells. Intercalated cells which are divided into two types: alpha intercalated cells and beta intercalated cells. These intercalated cells, as with the word intercalated, it means something which has interspace or put into among other things. Like we put intercalated cells between principal cells, so they are not there in high concentration compared to principal cells. So what does these intercalated cells? As you can see, aldosterone works right here, right to excretion of acid. Acid keeps to be added in the urine. Acid still, and we reabsorb some part of potassium, and still bicarbonate keep being reabsorbed. Here at beta integrated cells, this is why we are able to excrete bicarbonate and then reabsorb chloride. This can happen just in case we have alkalosis. This cell might be activated. We have alkalosis, then we reabsorb acid, and then we excrete bicarbonate from the point of homeostasis. So far, what is the component of our urine? We have a urea that we have found nowhere to get reabsorbed. We have a creatinine. We have potassium. And we have some bicarbonate. And you have acid. And of course nothing except glucose that we found get reabsorbed 100%. Nothing that we have found it get reabsorbed 100%. Still you have some part of things that remain the urine. But there's something to pay attention. Creatinine never get reabsorbed. But urea at some point in the correcting tubules it is get reabsorbed for the purpose of maintaining interstitial osmolarity. As you know, the interstitial osmolarity has to be maintained so that the kidney can keep functioning for the purpose of water reabsorption. So that was it about introduction of how tubule function. This is